Yes, sir. We are live.
Thank you. So, good evening, everyone. I'm Vishal from Zydus Synovia. Welcome you all to this initiative by Zydus Synovia, which is called RUMA DG Conclave. It's a digital initiative, and that's why we are calling it as a RUMA DG Conclave. I'm very thankful to our today's speaker, Taral Parikh. And thank you very much, sir, for taking your time out today, your precious time for a very wonderful topic today, which is myths and facts in viral arthritis. Uh, Going into the brief about sir's introduction, I would like to introduce Dr. Taral Parikh. He is a consultant rheumatologist, MD Medicine, DNB Rheumatology. He practices in Ahmedabad in Zydus Hospital itself. Moving into a little brief about Dr. Taral Parikh, consultant rheumatologist. He has won a gold medal in pharmacology as well as pathology in second year MBBS. Moreover, sir has completed his JULAR online full course, which is a 2 years of course, 2013 and 15. Sir has won the IRA National Quiz for Rheumatology students in SGPGI Lucknow 2013. Moreover, sir is a member of Indian Rheumatology Association, which is IRA. And I would like to tell that sir has attended and presented in so many national as well as international conferences through paper and oral presentations. And there are 11 publications which are in the name of Dr. Taral Parikh. He has participated and he was the part of those researches. So thank you very much, sir. And I welcome you for this session, which is myths and facts in viral arthritis. Moreover, I welcome everyone in the audience for attending today's session, and I hand over session to sir. So over to you, sir. I'll just unshare and you can share your presentation. Thank you very much.
Thank you so much.
I request everybody in the audience, please put your questions in the chat box. At the end of this session, sir will take all the questions, all your queries, and he will happy to answer all your questions at the end of this session. Thank you, sir. Over to you, sir.
Thank you. So, am I visible?
Yes, sir. You are visible. Presentations are also visible.
Sure.
Slides are visible.
So, thank you. So, I'll just start with the presentation.
Yes, sir. Over to you. Thank you, sir.
Thank you. So, coming to today's presentation, we are going to talk about post-viral arthritis, because the viral infection in the beginning is an infection where the treatment is different from the rheumatological conditions, is usually antivirals and supportive treatment. So what we will be discussing here is what is the sequelae of these infections, and we'll today's topic, because of the current situation of the chikungunya epidemic we are seeing in Ahmedabad and other parts of Gujarat as well. So we will focus our talk on post-viral chikungunya arthritis, right? So this is how we are going to be proceeding. We'll discuss a case where we'll discuss the presentation. What is the laboratory diagnosis of chikungunya arthritis when the patient comes to you as arthritis after the infection? What will be the differential diagnosis? Because when the patient comes to you after 2 to 3 months of the viral infection, history and the previous lab features will help you in identifying what was the viral infection. Sometimes it's not very clear what it is, right? That is the differential diagnosis. Very importantly, not all viruses lead to rheumatological sequences. Some of them have long-term outcomes, and chikungunya especially has long-term outcome in terms of evolving into chronic arthritis or even other conditions like rheumatoid arthritis or spondyloarthritis. And what is the management in brief? How do we manage these patients once they have this long-term chronic sequelae? So if you look at viral arthritis, the main viruses which cause rheumatological features are many, including the parvovirus B19, hepatitis B, hepatitis C, HIV, the alpha viruses of which we have chikungunya, Zika, and the dengue viruses, which are the alpha viruses, and HTLV1, which is usually seen in Japan and Caribbean. We have not come across HTLV viruses in India per se. So if you look at parvovirus infection, it's acute febrile illness presenting in children, where they have this classical appearance of the cheek called as the slab cheek appearance, and it's usually asymptomatic in children, and self-limiting pattern of oligoarticular involvement can be seen in children. In adults, however, parvovirus B19 can cause rheumatoid arthritis like presentation, and even rheumatoid factor ANA can be positive with parvovirus infection. So differentiate from other rheumatological conditions is very, very important. If we come to hepatitis B and hepatitis C, these are the two endemic infections in the Southeast Asian population, and they can both cause an arthritis due to initial viremia or immune complex deposition, and both of them can cause chronic rheumatological sequences in the form of hepatitis B causing polyarthritis nodosa. But with the introduction of the hepatitis B vaccine, the incidence of polyarthritis nodosa has gone down quite significantly due to hepatitis B. And hepatitis C can be associated with cryoglobulinemia vasculitis. So these are the two chronic forms of rheumatological conditions seen with hepatitis B and hepatitis C. And there, a history of jaundice or hepatitis B, hepatitis C workup is very, very important, because the management there differs. In hepatitis B, is usually immunosuppressive, plasmapheresis, and antivirals. Well, hepatitis C, again, is antivirals, and if they fail, then only then we use rheumatological drugs. Coming to HIV, HIV again is endemic throughout the world. So in HIV, you can have arthritis in various phases of HIV. Initial seroconversion can present like acute viral arthritis with polyarthritis, and that usually resolves with the beginning of the HRT, highly effective antiretroviral drugs. You can get psoriatic arthritis, reactive arthritis. So any patient who has severe psoriasis and psoriatic arthritis in an elderly male, 40 to 45, 50, HIV has always to be kept in differential diagnosis. Coming to alpha viruses, so as we are seeing that since 2006 and 7, the chikungunya epidemic has been coming back in India in various parts of the country, including Maharashtra, Gujarat, Rajasthan, every 2 to 3 years. And we have been seeing a lot of chikungunya cases after the first 2006-7 epidemic. Even currently, since 2015 to 2020, every October to November, after the peak season of chikungunya infection, we have the viral arthritis patients coming in November and December. And HTLV1 is again a retrovirus related to HIV, and it can also present with arthritis and neurological symptoms as well. So if you look at the list, it's very exhaustive. Some of these viral infections are transient, while some like hepatitis B, HIV can be chronic persistent infections, where the treatment of the infection along with the rheumatological condition is equally important. Now, if we come to prevalence of chikungunya, as this slide shows, till 2019, most of the chikungunya cases have been in the southern hemisphere. So it is clustering around the region where we have poor hygienic conditions and mosquito breeding. So it's spread by the Aedes virus, the same virus which spreads the dengue virus. And we have been having epidemics in various parts. It started with Africa, the Reunion Islands, which were under the control of France initially, colony of France, and then it has spread to the Southeast Asian countries, and even the Southeast Asian Indonesian countries as well. And we also have a chikungunya epidemic in South America, Brazil, and even other parts of North America. So it's very, very important that we get seasonal chikungunya infections during the rainy season and monsoon season. And most of these do remit by the end of 1 week, but we get a chronic sequelae after 3 months. And so many patients who had come even in the initial 2005, 2006 epidemic are still following up with us for chronic arthritis. So now we present this case, and in this case only we'll try to highlight the facts and myths about the management or diagnosis of chikungunya arthritis. So coming to the case now, in November 2019, we have seen a female patient who is 45 years old with a 2-month history of symmetric polyarthritis, which was associated with tingling numbness in both hands that is suggestive of carpal tunnel syndrome, and significant morning stiffness of 1 hour, which is significant debilation on the part of the patient. If we took the history now, since anybody who has a symmetric polyarthritis in India, the viral arthritis should always be kept in diagnosis. Every polyarthritis need not be rheumatoid arthritis to begin with. So when we took the history, she did say that 3 months back, she started with sudden onset fever. So if the patient comes to us at the end of 3 months and no tests were done during the initial febrile period, this point of sudden onset of fever, the patient with chikungunya or dengue arthritis will tell you that the fever came all of a sudden, like the patient was sitting in the sofa at 5 p.m., he could not stand up. Similarly, patients who are sleeping would say, I could not wake up in the morning. So they remember the time and the date pinpoint. Whereas in rheumatoid arthritis and other rheumatological condition, the onset is usually insidious or subacute over a period of 4 to 6 weeks. They would not remember the day or time when they had these joint symptoms, which is very classical of a viral fever If the tests are not available still, that history tells you that this presentation is usually post-viral. Most of the patients are investigated, but there are some patients who are not investigated. It is presumed to be a chikungunya infection or a dengue infection in the periphery. Only a CBC is done, and the specific antiviral tests or the viral tests have never been done. And that's why it's important that we always look into the history. So she started with a sudden onset of fever, and the fever lasted for 2 days. There was a diffuse maculopapular rash all over the body, which also resolved over 3 days. And usually the patients do not tell about the rash. We do ask specifically that this sudden onset fever, rash, and the arthritis starts either on the same day or the next day is typically considered to be chikungunya or dengue arthritis. She didn't have conjunctivitis. There was no severe headache or loose motions or no other major organ complications according to her, and she did not require hospitalization for the same. Now, coming to the course of arthritis, when the patient had fever, she had polyarthralgias to start with. So there was pain, severe pain with stiffness, but she had not noticed any swelling. And this resolved within 1 week along with the fever and the rash. 1 month later, there was a flare of arthritis, and this time she has noticed, as we have discussed, joint pain, swelling, and morning stiffness, which are the typical or the cardinal signs of arthritis. And since last 2 months, these symptoms have become chronic and persistent, and they are not resolving spontaneously. There was a past history of autoimmune hypothyroidism, and the family history was negative for any autoimmune disease. Why this presentation is important? Because the presentation of arthritis differs in children and elderly. So children usually have a multisystem disease, more of neurological complications, and they don't get arthritis, while those who are elderly, more than 60, females, those who have osteoarthritis, or an autoimmune condition in the family like rheumatoid arthritis, or the patient has an autoimmune condition like autoimmune thyroiditis, vitiligo, they are more likely. These are the predictors where the patient have chronic arthritis after an episode of acute chikungunya. So that history becomes very, very important. So here, if you look at the myth and the fact, so the myth is that every presentation of polyarthritis need not be rheumatoid arthritis. Viral arthritis, including hepatitis B, C, HIV, dengue, as well as chikungunya, should always be kept in mind. That is a very, very important myth, that every symmetric polyarthritis is not rheumatoid arthritis. And even if your rheumatoid factor anti-CCP is negative, the history of viral infection to start with is very, very important. That is the first myth. And the fact is that the history taking more than the investigations will let you know the diagnosis. Now, if you look very briefly, which all of us know, what are the clinical features of acute chikungunya infection is fever. So every patient has sudden onset abrupt fever, arthralgias initially and arthritis later on. They also have myalgia, headache, rash, sometimes fatigue, diarrhea, and edema. But these are less common presentations. These features are more common with dengue infection rather than chikungunya infection. As we said, in children and young adults, there can be multi-system involvement in chikungunya as well, where currently we have a lot of patients admitted in a hospital with neurological complications like encephalitis, transverse myelitis, GBS-like presentation, cardiovascular, cutaneous involvement, pulmonary renal involvement, vascular phenomenon like hemorrhagic signs, gum bleedings, melena can also be seen. And rarely you can have liver and ocular involvement as well. This is less than 10 to 30% of the patients in the younger age group. 90% chikungunya is a mild fever, rash, arthralgias kind of a presentation, and the systemic form is usually very rare, which requires multidisciplinary approach along with other specialties as well. So this is very important in a setting in the Western India, like we see both chikungunya and dengue, and with the current coronavirus epidemic, we are seeing a lot of patients with chikungunya with COVID and dengue with COVID. And as we all have seen, these cases are also being reported from Delhi and Mumbai, and they have worse outcome. So both the viruses, if they occur together, the COVID and the chikungunya or dengue and COVID, then usually the management becomes much more complicated, both in terms of lab interpretation and absence of any specific antiviral agent for either of these infections, and the mortality increases. So if you look, these are a few pointers. There is no 100% way to rule out dengue or chikungunya without the specific viral tests. But historically, the fever is sudden and very high grade fever in chikungunya as compared to dengue. The arthralgias is much more in chikungunya as compared to dengue. Dengue patients complain of body ache and not arthralgias, and there are more of myalgias. There is more headache. Rash is usually much less. There is much of the purpura due to thrombocytopenia, and the diffuse maculopapular rash goes towards the chikungunya arthritis. And the severest form of dengue, which we see, hemorrhage, and shock is usually not seen with chikungunya arthritis. In the lab diagnosis, when the patients come to us after 3 months and we look at their blood test, which were done 3 months back, we look for lymphopenia, which is more suggestive of chikungunya, as compared to neutropenia, which is seen with dengue patients. The thrombocytopenia in patients with chikungunya arthritis is usually modest, usually between 1 to 1.5 lakhs, and it is not as severe as we get in patients with dengue, where the thrombocytopenia can be quite significant with platelets of around 50 to 30,000 and with hemorrhagic manifestations. This leads to hemoconcentration. So you have a hematocrit going up and the complications related to that, which is absent with chikungunya infection. So in this patient, when we asked the patient, can you show us the previous blood test when you had this viral fever? She had initial counts which showed a leukopenia, which was lymphopenia for most of the part. Platelets were around 1.2 lakhs. ESR was 50. LFT creatinine was normal. And the chikungunya IgM was negative, which was done on the third day of the fever. The NS1 antigen was done at that time, which was negative. When we saw the patient right now, we had to make sure that we are not dealing with a chronic chikungunya arthritis or something like rheumatoid arthritis. That is also possible. So we repeated the blood test where the CBC normalized. The ESR was 45, the CRP was 22. So the acute phase reactants were elevated. Since it was already 3 months of presentation, we need to make sure that we are not dealing with rheumatoid arthritis. So a rheumatoid factor and the anti-CCP antibody was reported, which was negative, and the chikungunya IgG was positive. So if we look at this slide, what is the myth and what is the fact? Fact is that, as we have discussed, that the differential diagnoses are broad. So dengue, chikungunya, malaria, at least these viruses have to be carefully ruled out at baseline. And the myth is that the chikungunya tests are used very specifically. The chikungunya tests have to be ordered at a very specific time to find them positive. If you do the chikungunya tests at the wrong time, then what you will get is that when the patient had the fever initially, the tests were done at the wrong time and the diagnosis becomes much more dicey. And sometimes by the end of 4-5 months, even the IgG titers fall. As we are already seeing with COVID infection, 90 to 120 days, the IgG responses do go up in most of these viruses. So what is the diagnostic criteria for acute chikungunya fever? In our setting, in OPD, if the patient doesn't have the blood reports, it's very simple. Our diagnosis is the definition of a suspected case. Any patient who starts with acute onset of fever with rigors or chills, which lasts for 3 to 5 days, associated with arthralgias, that is pain and swelling of the extremities, which is still persisting at 3 months, is always a suspected case of chikungunya arthritis, even if your PCR or chikungunya IgG IgM is absent. And this happens in most of the time. If the patient comes at 6 to 8 months, all the blood tests will be normal. So this history of acute onset of fever, rash, arthralgias for first 1 week, and then persistence is very, very classical of chikungunya, unless a dengue, malaria, or other infection was proven at the beginning of the fever. What is the probable case? So anybody who lives in this area of endemicity of chikungunya, that is Southeast Asia, Africa, or history of travel to this area during the seasonal incidence of chikungunya, and the ability to exclude malaria, dengue, and other causes of viral or other fevers. So if that has been done, that makes it more likely to have a probable case. And once you confirm that the viral etiology was chikungunya, then it is a confirmed case. So if you have virus isolation, where in India we send to NIV Pune, we don't have virus isolation in cell culture or animal inoculation anywhere in our part of the world. We usually do RT-PCR. That is the same RT-PCR we are doing for the COVID viruses. So we detect the specific viral RNA in the RT-PCR. Then comes the phase of IgM antibodies, which you see in a single sample in the acute or convalescent state. And if you look at the IgG, you have to look at a 4-fold increase of the IgG responses, which are collected at least 1 month apart. So if the IgG levels increase by 4 times, it is very, very specific that the infection which started with fever was a chikungunya infection. So as this slide very clearly shows, if you can look at this slide, for the first 7 days, from the 3rd day, your RT-PCR will be positive. So the problem with the patient was that a chikungunya IgM was ordered on the 3rd day of the fever. And this is very, very common. Lot of physicians, lot of general practitioners, lot of people practicing order the IgM at the wrong time. So if you order the IgM in the first 1 week of onset of fever, the IgM will be negative. The IgM usually starts peaking after the first 1 week and then it can persist for months. And the IgG usually starts rising after 3 to 4 weeks, and then it can persist for years in some patients. So if you order a test to confirm chikungunya in the first 1 week, it has to be a chikungunya RT-PCR and not an IgM. And similarly, once a patient comes to you after 2 to 3 months of chikungunya, you don't repeat either the RT-PCR, neither the IgM. You have to order only the chikungunya IgG. This helps you in diagnostic, and it unnecessarily wastes money for the patient and resources, and it is not helpful. So again, the fact here is that if the patient has suspected chikungunya in the first week of fever, never order an IgG IgM test. Only the RT-PCR will be positive. After 1 week, the IgM will be positive. And if the patient has a chronic presentation of 3 to 4 months of persistent arthritis, the chikungunya IgG is the one which will give you the diagnosis. Now, in this patient, the examination is very, very important, because on examination, you have to differentiate arthralgias and arthritis. So there is presence of just joint tenderness or joint swelling as well. So there was active synovitis of the proximal interphalangeal joints, metacarpophalangeal joints, the wrists, knees, and ankles. So that is a typical polyarthritis symmetric presentation of a patient with rheumatoid arthritis, which is very characteristic of chikungunya arthritis. The shoulder movements were extremely painful, both active and passive range of motion, showing an intra-articular involvement. And there was extensive tenosynovitis at the wrist and the dorsum of the wrist. So this extensor tenosynovitis is usually very common in chikungunya arthritis patients. And this extensor and flexor tenosynovitis is responsible for the carpal tunnel syndrome, which is present in quite a lot of patients who come to us with arthritis. So the hand grip was weak. There were flexion deformities at PIP and MCP, but they were reversible, so they were still acute and not chronic. The tendons and phalanx sign for the median nerve were positive. The systemic examination was normal, and back and neck examination was normal. So now this is a paper from Nature Reviews which has shown how does a acute chikungunya present with joint symptoms, how does a chronic chikungunya present with joint symptoms. And the colors you can see are from different part of the world. So the red is the Reunion Island, which is the first epidemic of chikungunya way back in 2006 and 7. Then we have from the Saint Martin, that is again the blue color, and the green color is the incidences from India. So if you look very carefully, the presentation is just like rheumatoid arthritis with your shoulders, elbows, wrists, the PIP-MCP involved, the hips, knees, ankle, and the metatarsophalangeal joints, which are involved both in the acute phase and in the chronic phase. And the back can also be involved in chikungunya arthritis, unlike rheumatoid arthritis, where inflammatory back pain is not present, that goes towards spondyloarthritis. And if you look back into the chikungunya terminology, the meaning of chikungunya in the original African language is somebody who's bent forward. So they could see the patients who were so severe back pain that they would be bent forward, stooped like an elderly lady for 4 to 6 weeks, and they could not even stand up and walk due to the stiffness of the back. So this back involvement is very specific with chikungunya arthritis, which usually you don't see with rheumatoid arthritis. So that is one pointer towards post-viral arthritis. Second, some of these patients can also evolve into spondyloarthritis. So that is also important. And then you have to make sure that you are not dealing with a spondyloarthritis rather than a post-viral arthritis where you have a specific form which is called as reactive arthritis. So that again, differential diagnosis comes in, but this is the classical presentation in acute and chronic chikungunya arthritis with a lot of polyarthritis, spondyloarthritis-like presentation, lot of tenosynovitis and carpal tunnel syndrome. And a lot of these patients remain chronically deformed due to the thickening of the tendons. The tenosynovitis leads to thickening and flexion contractures in the hands. There are so many patients who had chikungunya in 2006, 7, 8 who did not get adequate treatment or adequate physiotherapy, and they land up with chronic deformities of the hand due to tenosynovitis, just like a patient with rheumatoid arthritis, right? Coming to imaging, why imaging is important is because in the acute to subacute form, the chikungunya arthritis usually is non-erosive, whereas rheumatoid arthritis can show up erosion within first 4 to 6 months in hand and initially even in the feet. So the first erosions or first sign of damage in rheumatoid arthritis is not in the hands, it is in the feet. And the fifth MTP is the most specific joint which has been seen both on X-rays, ultrasound, and MRI to show the erosion. So earliest erosion in rheumatoid arthritis is in the feet and not in the hands. And similarly, when we see these patients at 3 months, we make sure that we are not dealing with an early rheumatoid arthritis. So the X-ray is the most simple way to look at it, where you see only soft tissue swelling. There would be no demineralization, joint space narrowing, and erosions in post-chikungunya arthritis initially. The USG was ordered to see for the presence of synovitis, and there was synovitis in the small joints of the hands. which is seen with the grayscale, and the Doppler showed increased vascularity, which confirms that it is an inflamed synovium. And there was tenosynovitis along the extensor tendons and the flexor tendons to a certain extent as well. And even on the USG, we did not pick up any erosion. So this makes a case historically, lab-wise and imaging-wise, more of a post-viral arthritis than an early rheumatoid arthritis. So one myth which is always there is that chikungunya is always a mild arthritis and they don't land up with deformities or erosions. That is a very big myth. A proportion of patients, up to 20 to 25% of patients who have chronic chikungunya arthritis will have deformities and erosive disease just like a rheumatoid arthritis patient, and the burden of disability can be as good as rheumatoid arthritis. So these post-chikungunya patients should not be taken lightly, that we give NSAIDs for 6 months, 8 months, we just give hydroxychloroquine, and this gives time for erosions and joint damage to set in. If the arthritis is persistent at 3 months and there is good going synovitis, they have to be treated aggressively like rheumatoid arthritis. So this is a paper which is from Japan, where they have done a study of 6 cases. And as we all know, the MRI picks up the erosion and synovitis much better than physical examination or an X-ray, but due to the cost and lack of availability, it is not done in routine cases. But as you can see in this patient, if you look at the left wrist of this patient as the arrow is pointing, there is an erosion in the carpal bones, right? You can see in the distal row of the carpals, there is an erosion there. And you can also see an erosion in the proximal. You can see that the erosions, the arrow, and the right hand corner is showing the synovitis. So this is a post contrast MRI, which is showing synovitis and effusion in the wrist joint. So that is a very big myth that chikungunya arthritis is mild, benign course. It can be chronic, severe, and it can have the same kind of deformity and functional deformity akin to a rheumatoid arthritis patient requiring aggressive treatment. So this is another issue which we have to keep in mind, that 90% of the chikungunya arthralgia or arthritis resolves spontaneously by the end of 3 months, and they require only physiotherapy, analgesics to start with during the acute febrile phase, and anti-inflammatory if the pain persists for up to 4 to 6 weeks. So what is the incidence of conversion to chronic sequelae in patients with chikungunya arthritis? So in our experience and a paper which we had published way back in 2006-7 after 2-3 years of epidemic, was that around 10 to 5%, not more than that, 5 to 10% have chronicity, 90 to 95% resolve within 3 to 6 months. So there is a paper which has elegantly seen the seroprevalence of chikungunya arthritis among rheumatoid arthritis patients, and what they found is that there is a high incidence of recurrence and chronicity of joint symptoms with chikungunya arthritis and persistent inflammation. In chronic phase, the disease is very similar to rheumatoid arthritis, and the prevalence of rheumatoid factor can range from 25 to 45% depending on the population and the method of rheumatoid factor testing which has been done. So up to 25 to 45% patients can be positive, and 1 to 5% can also be positive for anti-CCP antibody. And there it is very important to make sure that the patient does not evolve into full-blown rheumatoid arthritis. So regular follow-up is very, very important. After the initial manifestation, that is the fever, rash, and arthritis, there is usually a recurrence of arthritis. So this is called as a double peak sign, which happens in chikungunya arthritis patients who have chronicity. So there are 2 peaks, one at the presentation, and in between for 4 to 5 weeks, the patient is much better. And then there is a second peak, and that episode of arthritis does not settle down. So such recurrences can be 80 to 100% in first 6 weeks, and up to 12% up to 5 years. So just as we discussed in our series, we found around 5 to 10% had chronicity. Here also they found about 12% chronicity up to 5 years, right? Now coming to the diagnosis and management, what we do in this patient, especially the case we just saw, that she had persistent arthritis for 2 months. Already there was carpal tunnel syndrome, significant morning stiffness, and these patients would go on to develop more severe forms of arthritis. We started with injectable methylprednisolone, which is usually used as a bridge course, even in rheumatoid arthritis and flares of rheumatoid arthritis. So that helps in taking care of the pain for first 2 to 3 weeks. And that also helps for your DMARDs to start acting, because DMARDs take at least 3 to 4 weeks to start action. So we started with injectable methotrexate 15 milligram intramuscularly every week with hydroxychloroquine 300 milligram as the initial treatment along with the intramuscular steroid injection. Now this is very, very important when you look either at rheumatoid arthritis or you look at any inflammatory arthritis. Methotrexate acts much better as an injection rather than an oral medicine, especially when the dose is more than 15 milligrams. And the rapidity of action of injectable methotrexate is also much faster than oral methotrexate. Oral methotrexate takes 4 to 6 weeks. Injectable methotrexate takes 3 to 4 weeks. And this is the recommendation by the American College of Rheumatology, that in every patient with acute or an early RA, injectable methotrexate is superior to oral methotrexate, especially when the dose is 15 or more than 15 milligrams. The absorption also increases. The rapidity of action is also better. And the third thing which we see in clinical practice is oral methotrexate sometimes can cause a lot of nausea, and this can be troublesome for the patient, and that is solved with the injectable form. So that gives the patient confidence on methotrexate, or if there is vomiting due to first 2 or 3 doses, the patient will never take methotrexate again. So that is circumvented by injectable methotrexate. And then at the end of 4 to 6 weeks, if the patient is better by 40 to 50%, we can convert it to oral methotrexate, giving it at least 6 months for the full effect. Now, this point is very important. That every patient who has hand symptoms with tenosynovitis, flexor or extensor tenosynovitis, and early deformities, they have to go aggressive physiotherapy, because the pain, swelling, and the symptoms of inflammation will improve with the treatment, the DMARDs, NSAIDs, or steroids which we are giving. But in the long term, physiotherapy is the only thing which will give them the full function of the hand, shoulders, which are stiff. So physiotherapy is very, very important, and we cannot put much more emphasis on this to every patient than we can, that the patient has to start with physiotherapy from day one. So there is absolutely no contraindication of passive physiotherapy even in the acute phase. And once the acute phase goes on, patient can start with active physiotherapy as well. So when we saw the patient at the end of 6 weeks, that is in December, the patient was already in remission. So we converted into oral methotrexate and hydroxychloroquine 300 milligram. And we have kept the patient follow-up at 2 to 3 months interval, making sure that the disease does not progress. And then once she's in remission at 1 year, we can start to taper the DMARD. So as we are seeing the patient now, we have seen the patient in August, the patient was in remission. So we have started tapering down her DMARD. So first we like to reduce methotrexate. And if the methotrexate stopping does not cause a flare, we usually try to taper hydroxychloroquine at the end, because it is one of the safer drugs. So this is very important. Even with the COVID situation, it's a myth that hydroxychloroquine is an unsafe drug. Hydroxychloroquine is a very safe drug. Hydroxychloroquine is being used in rheumatology for past 70 years. We are aware of all the side effects. The most common side effects is reversible darkening of the skin. Some patient can get gastritis. Retinopathy, the bullseye maculopathy, is very, very rare. It is less than 1 in 10 lakh patients with rheumatoid arthritis, and it is only if you exceed the dose of 5 milligram per kilogram, or if you have taken hydroxychloroquine for more than 5 years. So it is not that common to get bullseye maculopathy as well. And if you closely look at the dose of hydroxychloroquine used in COVID patients is 800 milligram twice a day, which is far way more than the recommended dose of 5 milligram per kilogram. So if you stick to 5 milligram per kilogram of dose of hydroxychloroquine, it is one of the safest drugs, and the cardiac toxicity, even with azithromycin, is not seen clinically. It's only if you exceed the dose of 500 milligram per kilogram. And you also have to remember that the COVID virus itself causes myocarditis and cardiac thrombosis. So whatever has been attributed to hydroxychloroquine has caused a lot of fear and panic, not only among the medical community. People have started dissuading the patients from taking hydroxychloroquine, and even in the patients that we are taking hydroxychloroquine for the last 15, 20 years, does it really cause cardiac toxicity? So that's a very big myth, that hydroxychloroquine stuck to the 5 milligram per kilogram dose, what we use in rheumatology, causes any serious cardiac events. Although there is one paper which has been published in the American Journal of Rheumatology, a retrospective study where with azithromycin, due to the inhibition of the sodium and potassium channel, hydroxychloroquine can also cause QT prolongation, but that is usually only at higher doses of hydroxychloroquine. So we start with 400 milligram and we come down to 300 and 200 milligram in 6 months. So never use 400, 600 milligrams of hydroxychloroquine for long term, even in chronic arthritis or rheumatoid arthritis, because that will cause you side effects. Again, not the cardiac, but bullseye maculopathy is there. Cardiac and myopathy is very, very rare, extremely rare. And extremely rare, you can get a Stevens-Johnson syndrome as well. But these are extremely rare. Hydroxychloroquine is a very good drug. And methotrexate is also a very good drug, because once the patient starts as chronic arthritis, you have to treat as early rheumatoid arthritis. And the go slow, that technique doesn't work in patients with chikungunya arthritis. They land up with chronic deformities. So here is one plan. This varies from patient to patient. So what is very important in the treatment part is that during the acute phase, avoid using NSAIDs. The patient have thrombocytopenia, and NSAIDs should be not used. Only analgesics should be used. Steroids should not be used in first 4 weeks of chikungunya infection or any viral infection. It can be dengue, it can be chikungunya, because that can cause persistence of viral infection and the clearance of virus can be delayed. So unless it has been first 3 to 4 weeks, we don't use steroids in patients with chikungunya arthritis. They have to be managed with analgesics, because 90% of them will resolve within first 3 months without any deformities. Only once you start having your arthritis beyond 3 months, or the patient requires steroids, or the patient requires anti-inflammatory, if the patient is not able to stop, then we start using the DMARDs. So as they have seen here, once the patient comes to you in a chronic phase, you can see on the left hand side, you start with hydroxychloroquine, 6 milligram per kilogram once a day, and the maximum is 400 milligram. This is an older paper. So now it has come down to 5 milligram per kilogram. And usually it takes 6 to 8 weeks for hydroxychloroquine to start acting. So once the patient comes in follow, we see for chronicity, and if there is persistent signs of inflammation, synovitis, then we will add a second drug. Now this is something which is a controversy. Like rheumatoid arthritis, we don't have enough evidence. In chikungunya arthritis, there have been a few small studies, retrospective studies, only a few prospective randomized control trial. So you can either start with sulfasalazine as a second DMARD after 4 to 6 weeks, or you can start directly on methotrexate. That again depends on the patient profile and the patient's symptoms. So if the patient remains mild to moderate after 6 to 8 weeks of hydroxychloroquine, you can use sulfasalazine as a first add-on treatment. And if the patient has severe symptoms after 6 weeks of hydroxychloroquine, you can add methotrexate. So the doses of all the drugs are very standard. Sulfasalazine goes up to 3 grams per day in 3 divided doses. Unless the patient has gastritis, nausea, you can come down to 2 grams per day. And methotrexate, you start with 15 milligrams, either oral or injectable, and go up to 20 and 25 milligrams. 25 milligrams is the recommended doses by the American College of Rheumatology. In all chronic arthritis, you cannot see methotrexate has failed until you have used methotrexate 25 milligrams per week. So you keep on adding a second DMARD just as you do in rheumatoid arthritis, and assess the patient every 4 to 6 weeks and then 6 to 8 weeks. And if there is persistent inflammation, you can continue the same medicine. So as you can see on the right hand corner, the last slide, when the patient has chronicity, even after adding hydroxychloroquine or sulfasalazine and methotrexate, the patient has to be referred to a rheumatologist, because there can be some other viral infection which presents as chikungunya. There the treatment changes. The patient may have evolved into some other rheumatological condition like SLE, Sjogren's, spondyloarthritis, where the diagnosis becomes important, and there the rheumatological management will also change. Depending on the extra-articular manifestations, somebody can have ILD, somebody can have nephritis, somebody can have cutaneous manifestations, somebody can have hematological manifestations. So there the diagnosis has to be widened. Don't think that every chikungunya arthritis can present just as rheumatoid arthritis. That is a myth. The fact is that these patients, if they have underlying autoimmune conditions like thyroid, vitiligo, diabetes, or a family history, they can evolve into any other rheumatological condition. And there, the diagnosis and the testing becomes very, very specific depending on what we see in this patient and what extraradicular features are present. So any patient should not be ordered what we call as a RA panel or autoimmune panel, which has ESR, CRP, rheumatoid factor, anti-CCP, ANA, ANCA, and HLA-B27. They have to be ordered only on the basis of the clinical judgment. So if somebody evolves into spondyloarthritis, I'll do an X-ray or MRI of the back with HLA-B27. If somebody starts developing cytopenia, rash, oral ulcer, hair loss with arthritis, I'll start looking for ANA. Again, the age is important. That lupus presents usually in 20 to 45 age group and not after 50 and 60, which is the age for chikungunya arthritis. So don't do an ANA. Just because you need to do an ANA, it has to be only be done if the clinical features are suggestive of connective tissue disease. And somebody who presents with inflammatory back pain, which has persisted over 3 to 4 months, and a spondyloarthritis has to be ruled out, then HLA-B27 has also to be done. Right? So that comes to the end of my slide. What I would like to share with you in post-viral arthritis is that we are in very early phase of the coronavirus disease epidemic. We have seen patients with a lot of myalgias and arthralgias. We have not seen a chikungunya like post-COVID arthritis. I had unfortunately one patient who began like a COVID, cough, fever, and there were ground-glass opacities on the CT scan, and the patient was COVID RT-PCR positive, and the patient recovered in 1 week, and 4 to 6 weeks later, she had a persistent polyarthritis, just like a chikungunya or rheumatoid arthritis. Again, her rheumatoid factor anti-CCP was negative. So she was again tested for RT-PCR, which was negative, and we have treated this patient as post-COVID arthritis. But these are very few and very rare occurrences of post-COVID persistent arthritis. Most of them have myalgias to persist for long and fatigue to persist for long. The specific symptoms of arthritis akin to a dengue or a chikungunya arthritis is extremely rare as of now in the 7 to 8 months that we are getting series from all over the rheumatology departments from the world. We had one patient who had a classical post-COVID polyarthritis. So she started with COVID in July, and in August, she did have arthritis to persist. It was 6 to 8 weeks of persistent arthritis. There we have to start with hydroxychloroquine and methotrexate after the RT-PCR test is positive. So with this, I'll come to an end of the session, and I'll just brief about a few facts and myths to summarize. So the fact is that every polyarthritis, you have to take a history of viral arthritis. Myth is that every polyarthritis is not rheumatoid arthritis or lupus. Post-viral arthritis has to be taken into consideration. Fact is that a simple CBC and history can differentiate dengue from chikungunya and even COVID. You don't require all the tests if they are not available. And if you do the tests, the fact is they have to be done at the right time. So the first week has to be an RT-PCR for chikungunya. From the first week onwards, IgM up to the first 4 weeks. And in chronic phase, it has to be a 4-fold increase or a positive IgG response, which is diagnostic. So this is important that we should not order IgM in the first week of chikungunya arthritis. Otherwise, we'll get a false negative test. Another important fact is that chikungunya arthritis has a burden like rheumatoid arthritis, and they are mild, benign is a myth. They can evolve into erosive arthritis, so management has to be aggressive. The fact is that all these patients can also develop into other differential diagnoses, and everybody does not have chikungunya arthritis alone. So testing and widening a diagnosis is very, very important. And the fact is that the disability is as good as rheumatoid arthritis. So aggressive treatment, as we say in rheumatoid arthritis, aggressive treatment. We have reversed the pyramid. The initial pyramid was to start slow, gradually build up your DMARDs, and then you go over to next DMARD. But now the pyramid has reversed. Some of the expert rheumatologists would also say you hit hard. You give biologics in the first 6 months of rheumatoid arthritis, and so that you can abandon the inflammation, and then the patient can be switched over to DMARDs, and then they may come off treatment. Similarly, in chikungunya arthritis, you have to be aggressive in terms of pain management, physiotherapy, and your DMARDs. And once the patient starts resolving the symptoms, then gradually you can taper off. But it takes almost 1.5 to 2 years for these chikungunya arthritis to come off treatment. And the fact is that some of them are still on treatment after 10 to 15 years. So it's a myth that all chikungunya arthritis will resolve spontaneously within 1 to 2 years. No, some of them being seronegative are still being followed after 10 to 12 years of their initial presentation. Right? With this, I end my session, and I would welcome questions. If there are questions, any, Mr. Vishal, can we have the questions, please?
Yeah, sure, sir. First of all, I must say thank you very much for this insightful session. And I'm sure that everybody has learned a lot from this session. Moving on to the question, sir, there is a question by Dr. D.K. Patel. Sir is asking that difference or D by D between viral arthritis and chikungunya.
So, as we know, chikungunya itself is a viral arthritis. So, the difference has to be between a chikungunya viral arthritis and other viral arthritis, which we have discussed throughout our talk. The history is very, very important. What kind of manifestations does the patient have? Sudden onset fever with rash arthritis is chikungunya. Gradual onset of fever with thrombocytopenia and neutropenia is more of dengue. Similarly, if the patient has sore throat, coughing with fever, is more likely to have COVID. Fortunately, we are not seeing other viruses like hepatitis B as an acute form because of the vaccination, or even hepatitis C. And we are also not seeing other forms of HIV arthritis. We have seen a couple of patients with HIV arthritis, but then they would have that history of being HIV positive, and initial first to 4-6 weeks would tell you. So the differential diagnosis will be on history, the physical examination, and the extra-articular symptoms. Like if the patient had jaundice, it's more likely to be hepatitis arthritis, then chikungunya or dengue arthritis. And the lab tests, including your CBCs, your LFTs, and other markers like the viral tests. So if you have NS1 antigen for dengue, you have the chikungunya IgM or the RT-PCR for chikungunya, you have RT-PCR for COVID as well. And your laboratory features, including leukopenia, thrombocytopenia, liver involvement, renal involvement, would tell you the differential diagnosis between different viral arthritis. And I can tell you it's very, very difficult. More and more viruses can present with rheumatological manifestations, including cytomegalovirus, Epstein-Barr viruses, herpes viruses. So the differential diagnosis has to be very broad. And depending on the history, physical examination, you can do the specific test to come to a diagnosis. And sometimes we take expert opinion from infectious disease specialists as well, which makes our job much more easier that which test is more likely to give us a diagnosis.
Yeah, there is one more question. I think it may a little bit away from our topic, but how much is the substantial role of hydroxychloroquine in COVID-19? As you have mentioned some
Uh,
COVID-19, so maybe it is related to
yeah.
that.
So if you look at COVID-19, most of this early enthusiasm of use on hydroxychloroquine, both as prophylactic and treatment of COVID, has been not substantiated in lot of studies, both retrospective studies and prospective studies. They did not find any evidence of hydroxychloroquine either alone or added to azithromycin benefiting in any COVID patients. There was one study which was published in NEGM where they used as post-exposure prophylaxis, that if somebody a contact of COVID patient and they gave hydroxychloroquine as a post-exposure prophylaxis, there also it did not prevent the onset of COVID symptoms. And the primary endpoints of all these trials are different, but in neither of the studies, excluding a couple of initial studies, most of the larger studies and randomized controlled trials have shown there is no effect or no efficacy of hydroxychloroquine either in post-exposure prophylaxis or use in treatment of COVID. We all know that there were some reports from Maharashtra and Gujarat that the doctors who were taking hydroxychloroquine or the policemen who were taking hydroxychloroquine had much lower rates of COVID-19, and also that these had lesser mortality. But these are all observational studies. Remember, what we observe is not true. The randomized controlled trials are still the gold standard. So that shows enough evidence that hydroxychloroquine has no effect, and there is enough evidence that please don't use hydroxychloroquine with azithromycin because the cardiac toxicity, sudden cardiac death, and prolongation of QT interval is a real risk in patients with COVID. So hydroxychloroquine, most of us have asked our ID specialists world over to stop using hydroxychloroquine. But the problem is that since we don't have any specific antivirals and hydroxychloroquine comparatively is a cheap and easily available drug, people are using it. But currently the evidence is against the use of hydroxychloroquine in COVID right now.
All right, sir. So these are the questions from the audience. With this, I must say once again, sir, thank you very much for such a wonderful and very brief but very insightful and in-depth discussion about myths and facts of viral arthritis. So I'm really thankful to you on behalf of Zydus Synovia and on behalf of entire audience who have attended today. Thank you very much to the entire audience having patience and taking time out today for today's session. With this, I close the session, sir.
Thank you.
And good night to everyone. Have a great weekend. Thank
Thank
you.
you. Thank you to Zydus and Avi as well. Thanks a lot.
Thank you,
Okay.
sir. Thank you.
Thank you.